We will discuss about the neonatal jaundice, its diagnosis, and what the treatment modalities we are using for the treatment of jaundice. So one will see how the neonatal jaundice and the babies, those who are having the jaundice, they looks like their body, the whole body is the color is when the baby is newborn, their color is pinkish red in color. But the baby, if the baby is having jaundice, it may be the physiological or pathological jaundice that we will discuss later on. uh, the color may shift from this pinkish or whitish or to the reddish to the yellowish color. Then next is, what are the learning objectives of this class is define neonatal jaundice, difference between physiological and pathological jaundice, state causes of neonatal jaundice, discuss the pathophysiology of the neonatal jaundice and describing the complications of neonatal jaundice, and what are the management, therapeutical management, and what are the nursing care for the baby with neonatal jaundice. The next is anatomy and physiology. So that already you have completed it in your previous years, first year and second year, and the beginning of the your professional course, that what are the anatomy of the pancreas and the liver and the process of bile in the liver. The next is, what is the definition of jaundice. So yellow discoloration of the skin and the mucus due to accumulation of excess bilirubin in the tissue and plasma in neonates more than 7 mg per dl. So if the bilirubin level is more than 7 mg per dl, then we will tell that baby is having the jaundice. So 30 to 50% of the term pneumonia and more of preterm, it is very common in preterm babies. So almost 30 to 50% of the term babies having the newborn jaundice. So see one more example, like picture of a baby, those who are having jaundice. Then a simple mnemonic for the risk factor in jaundice is J is jaundice within first 24 hours of life. Then A is sibling who was jaundiced as neonate. So if anyone is having their siblings having the history of jaundice at the time of birth, they are also at higher risk for the jaundice. And the unrecognized hemodialysis, if the baby is having some secondary illnesses like blood disorder or anything which is hemodynamic issues, so in that case also the more chances of having the jaundice. Non-optimal sucking and nursing, the baby is not taking the proper feed, in that also the baby is having the chances of jaundice. And the deficiency of 6G6PD, in that case also the chances of risk factor is, this is also the risk factor for the jaundice. Any kind of infection to the newborn, that is also leads to the jaundice. Cephalohematoma, bruising, East Asian and North Indian, these are the risk factors. Then next is, what are the causes. So the causes are further divided into physiological and the pathological jaundice. So one by one we will discuss all these physiological and pathological jaundice. So if the baby is having the pathological jaundice, that may rule out before 72 hours, or if the baby is having the physiological jaundice, that will appear after the 72 hours. So see the pathophysiology. So first one is the uptake, and unconjugated bilirubin is converted into the conjugated bilirubin, and excretion that takes place in the conjugated bilirubin, and excretion is conjugated bilirubin. And the again in normal patients, that bilirubin will excreted, but in that this bilirubin is accumulated in the body itself. Then the physiological causes. So what are the physiological causes? Increased red cell volume and increased red cell destruction, decreased conjugation of bilirubin, decrease UDPGT activity, increase enterohepatic circulation, decreased gut motility, decreased hepatic excretion of bilirubin, and decreased liver cell uptake of bilirubin, decreasing ligadin. The next is pathological causes for the jaundice: excess red cell hemolysis, defective conjugation of bilirubin, breast milk jaundice, metabolic and endocrinal disorder, increased enterohepatic circulation, substances and disorders that affect binding. Then there are other than these miscellaneous causes are also there. Then the assessment and diagnosis of the jaundice. First one is the history. We should, in most of the pediatric diseases or the disorders, we should take a detailed history, because half of the problem we can solve it with the history. So detailed history taking is very much important almost in all the patients, but especially in the pediatric patients. Then the onset and duration of, like how much duration it will take, so we can differentiate between the pathological, physiological or any other type. So onset and duration is very much important. Then the pain, nausea and vomiting, loss of weight, itching, color of stool, color of urine, and past history. If the mother is having any history of any infection or any metabolic or the any medical disorder. Then next is the examination of the baby. So how we do the examination? First we do the color of the skin, then the severity of the jaundice, then the anemia and liver, spleen, gallbladder and ascites. So all these parameters we should check while doing the examination of the newborn baby for the jaundice. So in the color of the skin, like how much area is involved, according to that we will identify the severity of the jaundice. Then next is the diagnosis of the jaundice. So how we do the diagnosis? First one is the lab test. So blood test we are doing total conjugated and unconjugated bilirubin, complete hemogram, blood group status, direct comb test, serum albumin and other lab tests if they are needed as per the patient's condition. Then second is radiology and USG. So we do the USG examination if we found that other comorbidities like ascites, or if the baby is having some other issues also. And urine, HV electrophoresis, osmotic fragility test and thyroid and LFTs and 6GDPD, 6G6PD screening. Then sign and symptoms. First is jaundice, and for the jaundice, yellowing of the eyes, yellowing of the skin, excessive bilirubin in the blood, that we can diagnose with the blood test. Then the caroticous bilirubin moves from bloodstream to the brain tissues. Then symptoms may include yellowing coloring of the baby's skin, usually beginning on the face and moving down to the body, poor feeding and lethargy. Then what are the complications of the jaundice? First one is a keratosis, which we have already discussed, that the bilirubin start accumulating in the brain tissues. Then another one is the most important, is often fatal. It's rarely may get complicated in the early stage. Also in the early stage we can resolve with the help of appropriate treatment, light therapy or the medications, or excessive breast milk if we are giving to the mother. In that case we can early manage the complications. Then what medical management we can do for the management of jaundice? So phototherapy we can give. So phototherapy can convert that bilirubin that is, the body is not able to digest the bilirubin. So in that case phototherapy, by giving phototherapy we are making it easy so that it easily secreted in the blood. And then next is Phenobarbital Therapy, that also we are giving for the management. Then the metal prophylaxis also we are giving, and if the needed in very severe cases, in that case we are giving the exchange transfusion. The next is what is phototherapy. So what all management we have discussed, like enlisted before, we will discuss one by one. So first one is phototherapy. So phototherapy, you have to see, like we are keeping the baby under the UV radiations by covering its genital area and eyes also. So why we are covering? So to prevent the uh, any damage to these like very sensitive areas. So when bilirubin level is more than 12%, in that case we should start the phototherapy and then discontinue when level fall less than 2 mg per dl of previous. Yes. Then next is babies under phototherapy. So how we do care of these babies, those who having the like under phototherapy. So see, so what is the mechanism of this phototherapy? Transbilirubin is now then converted into cis bilirubinesomer plus lumpy bilirubin by photo isomerization. Then next is excreted in the bile and urine without conjugation. Then the what are the techniques of giving this therapy? 6 to 8 day light tubes are mounted on a stand, and all electrical outlets are well grounded, so the no chances of any shock or electrical current to the baby or a patient. Baby is placed neck 45 centimeter away from the tube lights in the crib or incubator. Eyes are covered with eye patches to prevent damage to the retina by the bright lights. Gonad should also be covered. Phototherapy is switched on. The next is baby is turned every 2 hours or after each feed. Temperature is monitored every 2 to 4 hours, because the chances of hypothermia is also there, because we are exposing the patient's body to the extreme lights, like 6 to 8 lights were there, so it may cause a hyperthermia. So temperature monitoring is also very essential in that case. Weight is taken at least once a day. So every day we should take the weight at the same time. Then next is more frequent breastfeeding. So as you have already we have already discussed, like breastfeeding is must for the resolving of the conditions, like in jaundice also the breastfeeding is very must, and which is very essential and good for the baby. Urine frequency is monitored daily, because with that also we can identify whether the jaundice is resolving or not. In the next is serum bilirubin is monitored at least every 12 hours. So we should monitor the serum bilirubin every 12 hours. Phototherapy is discontinued if the two serum bilirubin values are less than 10 mg per dl. Then what are the contraindications? Liver disease or obstructive jaundice. Complications are in that case these are the contraindications of the phototherapy, and the complications are watery diarrhea, skin rashes, dehydration, bronze baby syndrome, and the retinal detachment. These are the complications of prolonged this phototherapy. See, before therapy the baby is like how the yellow color is like easily visible, and post phototherapy the baby see the difference between the skin color. The next is side effects of the phototherapy. Increase insensible water loss. Frequently breastfeeding is very much important, so because too much light exposure is there and we are keeping the baby open, so in that case the chances of water loss is more. The next is loose green stools, wait often and compensate with the breast milk. Skin rashes harmless, no need to discontinue phototherapy. Bronze baby syndrome occurs if the baby has conjugated hyperbilirubinemia. If so, discontinue phototherapy. Hypo or hyperthermia, monitor temperature frequently. So that already we have discussed that why the hypothermia or hyperthermia is there. Hypothermia is there because we are keeping the baby open. So in winters the chances of hypothermia is also there. So it is very much important to prevent hyper or hypothermia, to monitor the temperature. Then the phenobarbital therapy, ligadin in liver induces hepatic enzymes. Then bilirubin conjugated and conjugation and excretion, and the doses we are giving is 10 mg per kg day 1 loading dose, and 5 to 8 mg per kg day 4 days. This one is the maintenance dose, or to mother 2 weeks prior delivery, dose 90 mg per day. Then metalloporphyrin is third type of management we are doing for the jaundice patients. Bilirubin by inhibiting hemooxygenase, and tin and zinc are currently used. So see how we are giving this therapy. And the next is exchange transfusion, in which we are giving exchange transfusion to the blood transfusion to the baby. So with this technique we can reduce the serum bilirubin load to the baby. Then what are the indications? Rise of bilirubin more than 1 mg per dl per hour. The next is to improve anemia and CCF. What is CCF? Is congestive cardiac failure. Then the serum bilirubin is more than 20 mg per dl in first 24 hours. The next is the cord hemoglobin is 12 mg per dl and bilirubin is more than 5 mg per dl. Then next is, it is still the most effective and reliable method to reduce serum bilirubin. The procedure involves the incremental removal of the patient's blood and the simultaneously replacement with the fresh donor blood, saline and plasma. The patient's blood is slowly drawn out and an equal amount of fresh pre-warmed blood, plasma or physiological saline is transfused. Then the cycle is repeatedly until a predetermined volume of blood has been replaced. The next is risk and complications are cardiac and respiratory disturbances may can cause. Then shock due to bleeding and inadequate replacement of the blood. Yes, it may leads to the hypervolemia or hypovolemia that may complicate the situation. The next is infection, or like we are dealing with the central lines directly from the blood, so the chances of infection is also there to the patient. And then they don't have their immune system, so children are always more prone to have the infections. Then next is clot formation, so the chances of clot formation is also there. The next is rare but severe complication include air embolism, portal hypertension and necrotizing enterocolitis. So these are the complications which can leads after the exchange blood transfusion. The next is, what are the prevention? First one is breastfeeding. So for almost all the diseases, the first thing is, which is very much important, is breastfeeding should be encouraged for most women 8 to 12 times per day for the first several days. Assistance and education to the mothers, the right technique, how frequently you should give, and how to deal with the baby, how to deal with the initial breastfeeding problems, avoid supplements in non-dehydrated infants. So the proper counseling to the mother for the breastfeeding is very much important. Then ongoing assessment for risk of developing severe hyperbilirubinemia. Monitor at least every 8 to 12 hours. Don't rely on clinical examination, blood testing, prenatal ABO, RH type, antibody, infant cord blood. So ABO grouping of the mother and the father is like we can determine before the delivery that the baby is having the chances of jaundice. If the mother is having negative RH type, so in that case also the chances is more. Infant cord blood we need to test at the time of delivery, so we can early identify the things before they may get complicated. Then nursing management for the jaundices. Management is first is assessment, in that observing for the evidence of jaundice at regular intervals. Then jaundice is common in the first week of the life and may be missed in dark skin. So those who having the dark skin, in that case, it is difficult to identify the difference between the yellowish skin and the whitish skin, pinkish skin, or red skin. So appropriate assessment is very much necessary. Blanching the tip of the nose. So with this method we can identify the jaundice. The goals of the planning is infant will receive appropriate therapy if needed to reduce serum bilirubin level. The next is infant will experience no complications from the therapy. Then family will receive emotional support. Family will be prepared for home phototherapy is prescribed. So thank you. This is the topic for today. So hope you like it. So if you like my this class for the jaundice, you can hit like button, or if you don't like, you can hit press dislike button. So thanks for watching, your patience. Hope you like, and if you having any doubt regarding this class, or if you want any further classes or that topic, you can mention in the comment section. Hope you like. Thank you.